My name is Dr. Edward Evantash. I am an OB/GYN as well as the medical director at Hologic. I recognize the difficulties with keeping up with the latest literature and guidelines that affect our clinical practice. Our goal at Hologic is to identify relevant articles and provide a concise breakdown of the clinical highlights and conclusions. When I was practicing gynecology, I prepared a patient for an endometrial ablation by starting the counseling process and signing the consent form. Now, if the patient had a history of tubal ligation, laparoscopic or at cesarean section, or if at the time of the ablation they wanted to have a tubal ligation, I counseled them that there was a slightly greater risk for failure of the ablation than for women who did not have a previous tubal ligation. I also counseled them about a higher risk for developing PATS, post-ablation tubal sterilization syndrome. This is an adverse event where there is blockage of the fallopian tube from the sterilization and blockage of the lower part of the uterus from the ablation, and there may be some residual endometrium in the proximal fallopian tube that was unablated. Now, the residual endometrium would bleed each month, and there would be no egress of the blood through the proximal tube or through the lower uterine segment. And blood would then accumulate in the proximal fallopian tube and lead to swelling and pain on a cyclic basis. And this was all based on early research primarily done with first-generation endometrial ablation devices. An article was published by a group from Ohio in June of 2013 in the Journal of Minimally Invasive Gynecology. This group did a study with the primary objective to determine whether women who had undergone tubal ligation before or concurrent with the endometrial ablation were more likely to undergo hysterectomy than women who did not undergo a tubal ligation before or at the time of endometrial ablation. This was a retrospective study. They went through their database of patients who had undergone second-generation endometrial ablation procedures and identified 587 women between January 2006 and January 2010. 34 of these women were excluded, primarily due to the inability to complete the ablation at the time of surgery. The remaining 553 women underwent global endometrial ablation at their local hospital or private office. The predominant modality of endometrial ablation in this cohort was NovaSure radiofrequency ablation. The median range from ablation to hysterectomy was 563 days, and the range being just under a year to just under 3 years. There were 315 women in the cohort that underwent endometrial ablation and had previous tubal ligation. Of that group, 52 women required a hysterectomy, which is 16.5%. There were 238 women who did not have a previous tubal ligation but underwent endometrial ablation. 27 of those women required hysterectomy, which is 11.3%. This difference in hysterectomy rates, 16.5% and 11.3%, in the group that had tubal ligation and the group without tubal ligation, respectively, was not statistically significant. Pelvic pain was statistically significant in the tubal ligation group. However, neither the cause nor duration was determined or recorded. The present study did not demonstrate an association between tubal ligation endometrial ablation and hysterectomy. The difference in hysterectomy rates between patients who underwent tubal ligation after ablation, 16.5%, and those who did not have a tubal ligation, 11.3%, was smaller than anticipated and was not statistically significant. No association between tubal ligation with endometrial ablation and hysterectomy was found. So how will this affect your practice? When you counsel patients for endometrial ablations, patients who have either had a tubal ligation in the past or will be undergoing a tubal ligation at the time of the ablation, you do not necessarily need to counsel them that their risk of failure is higher than for women who have not had a tubal ligation. The risk of post-ablation tubal sterilization syndrome, or PATS, is still present for women who have tubal ligation and ablation. However, that risk is very small in patients who undergo a NovaSure ablation. According to the NovaSure Instruction for Use Manual, the risk of PATS is less than 1% as determined from the pivotal trial. Nevertheless, the risk of a patient developing PATS after NovaSure needs to be conveyed to patients, and that risk can exist up to 10 years.